looking back to now to future, I think that we're seeing these fellowship programs grow. So you're getting more people that have the training, which is, I think, very strong in the sense of expertise, right? So you're getting more individuals have a desire to be better and at the top of their field. That's sort of what these programs are designed to do. And I hope that trickles down to better practice across whatever organization, whatever standard of care and outpatient settings. That could be a new level set of a higher standard.
Today on Hands On, Hands Off, we're joined by a clinician, educator, and lifelong learner who is shaping the next generation of physical therapists while also expanding his own expertise. Chris Hagan is the coordinator of physical therapy services at IU Health, where he leads a busy outpatient clinic, mentors fellows, and lectures at the fellowship level. Now, his passion for orthopedic manual therapy and musculoskeletal care has also led him to Northwestern University, where he serves as a contract educator in musculoskeletal labs for DPT students. Yeah, all that. But Chris doesn't stop there. He's now pursuing his PhD in health sciences at Northern Illinois University, taking his commitment to advancing the field of physical therapy, quite literally, to the next level. Today we dive into his approach to mentorship, the critical role of setting patient expectations in clinical practice, very important, and his thoughts on some of the pressing challenges in healthcare, including access and reimbursement. With a wealth of experience in clinical practice, education, and research, Chris brings a unique perspective on how orthopedic manual therapy can evolve to meet the needs of both clinicians and patients alike. Don't move. This is Hands On, Hands Off. Chris Hagan, welcome to Hands On, Hands Off, as we shake hands.
All right.
Hands on, hands off. In Chicago right now.
Yes.
And then, so give people like a little context, like a level set, like what's your superhero backstory?
So let's see. We'll take it back to 2015. Graduated PT school from Northwestern.
Hang on one second.
Okay.
We get a little beard. There we go.
Sorry.
I don't have much facial hair. There you go. You're fine. We got a little beard audio.
Graduated from Northwestern back in 2015 with my DPT. And stayed in Chicago area ever since. So I did my residency with Northwestern right after that, and then my orthopedic manual physical therapy fellowship at UIC, and finished that in 2018. So since then I've been full-time therapist, treating patients, helping out, mentoring in the fellowship program there at Northwestern, and most recently teaching. So I'm helping a little bit of student teaching at the DPT level. And now, the last year, I've been in a more managerial role, coordinating a clinic at UI Health down in the city. So can't leave Chicago. So
and it sounds like you haven't found a setting or a thing to do that you don't like.
I know it's great. I definitely am in the outpatient world pretty strictly and love the ortho, but I like a lot of variety. So treating, administration, teaching, mentoring. And most recently going after more research stuff. Started my PhD this fall. So. Another thing to put on the plate. So,
yeah. Well, that was my great radio segment, my first question. Clinical education and now a PhD student. How do you balance those things? Where do you begin to find the balance in those things, and how do those actually help and influence each other in your day-to-day practice?
Yeah, it's a really good question. I'm still working on the balancing it all out answer, but because personal life too. I got
there's some of that.
Two kids at home. A third one coming very
Congrats.
soon. Thank
That's
you very
great.
much. Yes. So working on, how to juggle all that is still definitely a work in progress. But I think for me, the interest in adding to my research plate, which is, pretty thin, pretty small. So I want to just learn more in that realm and try to grow, stronger in that field. And ultimately, I feel like getting into academics and teaching is really where I see myself ending up down the road. However long that ends up being, I don't know. But I think that is one of the tickets to help get you there is that terminal degree. The DPT is clinical, so having a stronger terminal degree might help get there, and learn a lot along the way. So it's kind of a long-winded answer, but the balance is to be determined.
Yeah.
Staying in the realms of feasibility, so finding things that are applicable to where I'm at, applicable to what I'm doing.
And where you want to go.
Yeah, and tie into research. Yes.
So it sounds like, I've been guilty of this myself, which is what's next? I don't know, stuff, and I'll figure it out. It sounds like we had to do this thing that we I hated in PT school, I'll say it, which was self-reflection. And now I find myself doing more and more of that, and I guess my professors knew what they were talking about. But if you don't do that, you wind up doing a lot of things. That's where someone had the line where you could have 20 years of practice, or you could have 1 year of practice 20 times. You could have 20 years of anything, or 1 year times 20 of anything. But to really get to where you think you want to be and grow to what you want to be, you sort of have to think about it first and decide what the steps are.
Yep.
It sounds like you're doing that.
Yeah, a little bit.
Yeah.
A lot of reflection for sure.
Yeah. Yeah.
But it is strong advice. Reflect, and it makes you better.
Yeah.
So, yep.
So now you mentor and lecture at the fellowship level now.
Correct.
So what do you see as the most critical aspects of mentorship in the development of future orthopedic manual physical therapists? What's important?
Great question. It definitely maybe my own bias, but I feel like the differential diagnosis, and if we're staying on the reflection trend, that ability to reflect in action while you're listening to a patient tell you their story, or going through your objective exam and finding something you might not have expected to find. So having that ability to think very broadly and be very efficient and effective to get to some working diagnosis of what you're going to start with,
Sure.
right? It may not be correct, but you weaseled your way into something, and now you're going to start your treatment there. So I think that is something I try to push more in mentorship, probably more than other aspects, because if you can create that thought process with your patients, I think it's going to set you up for better success.
That's repeatable.
To get them better. Right.
That's repeatable.
Yeah.
The funniest part is what you had just said made me think, which was maybe one of the keys would be to remove that assumption. We go through school and we want to answer quickly, correctly and quickly, and a lot of times we jump to conclusions. Myself, and I know people do this because I do it,
yes.
and I try to beat that out of myself, but maybe it's if you were going to, instead of add something to that, it would be removing that assumption and doing the test that you didn't think you'd find a positive result on, but doing it and being sort of happily surprised, or surprised in a good way, because it might change things.
Yeah, that's a big, and confirmation bias is one of those very difficult things to correct, and I'm guilty of it too at times. And the time in your own session is a factor that makes you do that. But with the mentoring, we flip the script. It's you listen to this objective, and you should know what it is, pretty much, right? Have a really good idea what that diagnosis should be. And then any other competing things should really drive your exam to rule it out. So I kind of use that model of, if you think it could be X, Y, and Z, but you're really sure it's A, then test X, Y, and Z and make sure they're negative. So then you're really feeling strong about A, and then confirm it at the end. So kind of that removal of going after one thing.
Sure. Yeah. Now, you've spoken about the power of words. That rings true with me. With the background in journalism and communications, I realize and appreciate the power of words, and also in an expectation setting. And that's using your words to ask questions to make sure you're on the same page. Specifically during patient exams and treatments. Talk about how clinicians can better communicate with their patients with the goal of fostering trust and enhance outcomes. That's the goal.
Yes. I think this kind of goes into some things that I've seen in mentorship. I think often the learner is trying to use their skills and ask the right questions and find out what it is. And so often the patient is kind of left out of the blue, like they don't know what's happening.
Right.
So that might mean they're not aware. They're like, why are you touching me? Why are you pushing? Why are you trying to get my pain to come on? So I think if you don't have the word part, right, where you sit down and communicate, I'm going to do this, whatever. I'm going to do this test for your neural integrity. Like, you might be feeling something that is familiar. That's kind of what I'm looking for. Like, you're setting them up to expect something, and then you do it on their uninvolved side, and then you go in and try to find it. So I think that is sometimes removed. Maybe it's the pressure of mentoring,
Right.
But not having that, hey, this is what I'm looking for, this is why we're doing this, and then cluing them in, I think helps you be more efficient, because they're gonna give you a better answer, and then you can tie all of that back and tell them, this is what we found, this is what we're working on, and this is going to be your expectation for going forward with treatment.
And when someone understands, they're probably more likely to stick around, more likely to do what you've asked them to do, not told them to do, but asked them to do.
Yes, correct. I think it kind of builds that team. Can you help me? I'm finding this. Tell me what you feel. This is what I found. This is what I'm thinking. does that sound good to you? Like, I think just kind of always doing that.
Yeah.
And I think most people do, do that relationship of like, does that sound good? Are we on the same page? But then just that extra layer of having them kind of in the game a little bit, like they know what they're going to get. They
Sure.
yeah.
And if they're not, they won't be
right
for long, or they're going to nod at you while you're in front of you and then leave.
Correct.
And then that is gone.
Mm-hmm.
Yeah. Yeah. The importance of words. Now, in your clinical role, you've undoubtedly faced challenges around access to care. That's a topic that I was amazed at because PT was a second career to me. It never occurred to me, right? Coming to physical therapy, I never even thought about it because I always sort of had access to care. I never really thought about the people that didn't. I didn't understand that was a barrier. So not only access to care, but also in reimbursement. What do you think some of the biggest hurdles are that you've encountered, and what potential solutions do you think could improve those areas for clinicians and patients?
Yeah, it's a great question. It's like a never-ending challenge, I feel like, in healthcare. And one of the positives in my role is trying to curb that a little bit, trying to get access a little more streamlined, trying to help patients come in regularly and feel like they're getting consistent care. It is not perfect. I don't know that it'll ever be perfect, but it is definitely a big forefront of what we're trying to do in our clinic as far as access goes. And then the reimbursement, it's a tough one. I think it's not heading in the right direction, which definitely challenges. It kind of goes with access too, because you're either going to try to overly access yourself to get a better dollar on your reimbursement total, or you're going to try to play the same game and lose out on potential reimbursement, right? So it's a double-edged sword. I feel like I always lean towards the value-based care model. I think is something on the up and coming, which would really make an improvement on people coming, getting better, and then getting reimbursed versus just coming because they can come and they have the insurance benefit to come, right? I think that is where I would envision change being anything meaningful, is it has to come from, did you get better? Like, did we do something?
Sure.
And that should be a factor of what's reimbursed and what's not.
Yeah.
So
now you're an endurance athlete.
I am.
What's your punishment of choice?
Let's not go crazy with athlete. I don't know that I'm an athlete, but I do like to get the heart rate up for long bouts of time. Yes, I love the swimming, biking, running. So
Good.
Triathlon doer. I've been doing it for 8-9 years probably now. So yeah.
My line with triathlon, because I am a triathlete, which means I've just started one, doesn't mean I've ever finished one. I like to say it's triathlon allows me to be mediocre at 3 things in one day, and I like efficient mediocrity. That's really what I like.
That's right. You can't be good at one thing. You could be mediocre at 3.
At 3 things. But now, how's your personal experience with endurance training really influenced your approach to patient care, or maybe particularly in orthopedic and musculoskeletal settings? Because if you have an understanding of it, that insight's got to help somewhere.
Yeah, I think it is helpful if I'm reflecting on just taking it out of an athlete, like someone who does that stuff, because it's very easy to apply to someone who's coming in with knee pain and they got a marathon to run, and you can sort of relate to that dosage and what's going on with them. But that's not the meat of our population that we see. So, having some experience in really just exercise and pushing the limits of your capacity might not be a long swim or a long bike ride. It might be going up the stairs or getting around your house. So I think saying that, you can almost think of it as this training bout where, everyone's so accustomed to like, well, you got to run 3 miles, then 4 miles, then 5 miles, then 10 miles. So you're working yourself up. But if you translate that to, you're doing 5 sit-to-stands now you did 15, then you did 20. So I think that, like, not necessarily graded exposure, but that progression over time is something I find pretty meaningful. Like, you just can't jump from 0 to 100 so quickly and expect that you're going to feel good when you do it, right? So using it in the sense of a race, I kind of use that example a lot with patients. I think that helps maybe put a little perspective on it.
Or even just graded change. Like, we want change to occur. We know it's not short, because if you're going to go from wherever you start to finishing, or at least starting a marathon, you understand that, and being able to put that sort of in perspective, which is, we want to do something right now, or we'd like to do something right now that you can't do right now, or it's difficult or it's painful, whatever that might be. Is it wrong for me to assume that you think we maybe need to start somewhere and progress? And just putting that in frame of context, of course, people can, even if they've never run a marathon, can sort of picture. Of course, you wouldn't just run there's this weeks leading up to.
Right.
Be able to frame that.
I think it's better received. I feel like it's a good picture to see.
Yeah,
So, yeah.
It's a good example. Let's look in future. We've talked about past and present. Let's look at future. In terms of somebody who's continuously learning and expanding your expertise and family, how do you see the future of orthopedic manual therapy evolving in clinical practice, academics? What trends or innovations are you excited about in the future?
Yeah, I mean, it's a great question, and I think that looking back to now to future, I think that we're seeing these kinds of programs, these fellowship programs, grow. So you're getting more people that have the training, which is I think very strong in the sense of expertise, right? So you're getting more individuals have a desire to be better and at the top of their field. That's sort of what these programs are designed to do, and I hope that trickles down to better practice across whatever organization, whatever standard of care and outpatient settings. That could be a new level set of a higher standard that might intertwine with some value-based medicine we're talking about, because these could be the providers that you might go see first because they have better training and can help you get better maybe quicker, which would be a better model than where we're currently at.
Yeah. Last thing we do is we try to just sort of wrap things up.
Okay.
Right? Let's tie it up with a bow. What's your parting shot? What's something you want to leave with the audience and have them either remain thinking about, something you might have already said, maybe you want to reiterate, or something brand new?
It's a good question. I'd say, keep reflecting. I think that's been our theme kind of throughout, and it's something I'm currently doing as we're talking. It's, having that internal voice could be very helpful to make change if you're thinking about change, right? If you're not reflecting, you're not really changing.
Yeah.
So
I like that. We put that out on a T-shirt too, along with my triathlon mediocrity.
Put that on the back of the tri T-shirt. Yeah.
Chris, thanks for stopping by and sharing some insight, man.
Yeah,
We appreciate it here at 2024.
Yeah, thanks for having me. It's
Awesome.
great. Appreciate it.